All right, let's just dive right into this, shall we? Welcome to today's Explainer. We are tackling a highly provocative, honestly, truly fascinating bioethical paper regarding end-of-life care. We're looking at a concept that challenges everything we think we know about medicine, aging, and what it actually means to experience a good final stage of life. It's a massive paradigm shift that asks us to look beyond just keeping the physical body alive and instead focuses intensely on the subjective experience of the mind.
Here's our roadmap for the day. We're going to cover the fourth age crisis, introduce this wild PFA proposal, talk about redefining end-of-life care, navigate the massive ethical dilemmas, and finally, look at a framework for governance. Let's get to it.
So part 1, the fourth age crisis. Modern medicine forces us to ask a really tough question. What actually happens when medicine extends our life, but completely fails to extend the quality of that life? Advances in public health are great. They've given us incredibly long life expectancies. But this creates a profound, sometimes agonizing gap between just surviving biologically and actually experiencing well-being in our advanced age.
For a lot of folks entering what we call the fourth age, that phase of very advanced age and severe impairment, the daily reality of living in an institution can be, well, really harsh. We're talking about living years, sometimes decades, with zero realistic prospect of functional recovery. These patients are battling neurodegenerative diseases, the aftermath of strokes, and chronic disabilities. And sure, they are physically breathing, but they are often enduring severe social isolation, profound, crushing boredom, and just a total lack of meaningful stimulation. It creates this deep existential and emotional suffering that traditional medicine, it just really struggles to fix.
Which brings us to Section 2, introducing the PFA proposal. The paper we're analyzing today is called Paradise in the Fourth Age, a bioethical proposal for pharmacological pleasure in institutionalized elderly, by Juan Carlos Holland de Barcelos. And what's deeply compelling to me here is that Barcelos notes this whole idea was actually motivated by his own personal experience. He was watching his 82-year-old parent live with severe functional limitations. The proposal was literally born out of watching a loved one endure that exact existential isolation we were just talking about.
Okay, so let's pin down exactly what this is. Paradise in the Fourth Age, or PFA for short, is proposed as a highly regulated program to administer pleasure-inducing substances under strict medical supervision to consenting, severely impaired older adults. Now, it's absolutely crucial to understand that this is a structured, voluntary initiative. It is strictly for those who lack any real prospect of getting better physically. So to be clear, this is not for the general public, and there is no way this is some kind of recreational free-for-all.
The author explicitly frames the goal like this, quote, "The objective is not to cure, but to provide a dignified, pleasurable final phase of life for those whose physical or cognitive conditions make meaningful engagement with the world increasingly difficult or impossible," unquote. Essentially, this is about treating emotional emptiness and absolute apathy when physical healing is totally off the table.
Logistically speaking, how on earth would this actually work? Well, the operational mechanics would require incredibly strict controls. The paper suggests using standardized synthetic compounds designed specifically for safety and predictable effects, or alternatively, utilizing well-known psychoactive substances like opioids. But the catch here is that this requires strict governmental-level control over the distribution. Think about how highly sensitive chemicals are managed. It would only ever be administered in licensed facilities and directly overseen by trained medical professionals. No exceptions.
Moving on to Section 3, redefining end-of-life care.
To truly grasp this paradigm shift, we have to compare it to our current gold standard. Traditional palliative care is primarily aimed at relieving suffering, managing physical pain, nausea, emotional distress. And in really tough, refractory cases where that suffering just cannot be managed, traditional medicine often turns to palliative sedation. Basically, they lower the patient's consciousness, sometimes knocking them out completely, just to shield them from the pain. The PFA proposal, though, it diverges sharply. It specifically targets that existential emptiness. So instead of seeking unconsciousness through heavy sedation, PFA seeks an enhanced state of consciousness combined with pleasurable experiences.
The paper argues that this isn't necessarily a total replacement of palliative care, but more like a radical evolution of its philosophy. It moves the goalpost from merely reducing negative suffering to actively, intentionally promoting positive well-being in the final stage of life. The author even points out that in current palliative research, we already use joint statistical models to track quality of life trajectories at the end of life. So those exact same models could hypothetically be used to prove if PFA genuinely and measurably makes these patients feel better.
This takes us right into Section 4, Navigating the Ethical Dilemmas.
Now, as you might imagine, critics raise several massive, totally valid concerns here. First up is resource allocation. Should public tax dollars really go toward pharmacological pleasure instead of basic health care or fighting poverty? The author's counterargument is that democratic societies are constantly making value-based budget decisions, and providing a dignified, comfortable life to the very old is a completely just allocation of funds. Second big issue: how on earth does a dementia patient consent? Well, the safeguard here demands incredibly rigorous frameworks, relying heavily on surrogate decision-makers and advanced directives that were written back when the patient was still fully cognitive. Third, we have the risk of medicalizing aging, basically treating old age as a disease to be fixed with drugs, maybe even driven by social pressure to keep the elderly quiet. The proposed safeguard? Ironclad regulation to prevent any form of coercion. And finally, global health disparities. Wouldn't this just become a luxury for wealthy nations? The author totally acknowledges this, insisting that any governance must focus on fair access and transparent participatory decision-making to prevent widening the global inequality gap.
All of this brings up a foundational, really tricky question in bioethics. Is pleasure a moral good in the context of dying? End-of-life care is already this incredible balancing act. We navigate dyskinesia, which is prolonging life at absolutely all costs, euthanasia, which is assisted death, and orthanasia, which is simply allowing a natural death to occur. PFA introduces a completely new access to this whole debate, using pleasure as a form of active care. Does offering pharmacological pleasure undermine a dignified death, or does it actually elevate it?
To even begin entertaining that question as a society, the paper stresses that framing is absolutely critical. There's a very real danger that a program like PFA could inadvertently normalize psychoactive drug use or completely alter society's perception of recreational drugs. Because of that, PFA must be presented strictly as a medical treatment, a palliative intervention. It cannot, under any circumstances, be framed as a reward or a fun escape. It literally has to be treated with the exact same clinical gravity as a strict chemotherapy regimen or a major surgical intervention.
And that leads us to our final section, a framework for governance.
So if we were to do this, the author breaks down 5 necessary pillars to keep it safe. First, you need multidisciplinary ethics committees packed with geriatricians, ethicists, and legal experts. Second, strict governmental regulatory oversight to tightly license the production and the distribution. From there, it requires ongoing empirical research, think clinical trials, to continuously monitor outcomes and spot any adverse effects. Add to that transparent public engagement to openly discuss the risks and gauge social acceptance. And finally, strict safeguards. We're talking crystal clear criteria for who gets in, robust ways to detect if drugs are being diverted, and instant revocation protocols if the system is abused in any way.
Here's the main takeaway. Regardless of where you personally fall on the ethical spectrum with this proposal, it forces us to look hard at our core values. Ultimately, this entire debate is driven by our respect for human autonomy, our deep desire to maintain a patient's dignity, and exploring whether people have a fundamental right to a meaningful, emotionally rich final phase of life, even when their bodies are giving out. Above all, it highlights the absolute necessity of having a serious, open, public, and academic debate, especially as our global population continues to age at unprecedented rates.
I'm going to leave you with this striking question to ponder. As medical science pushes our life expectancies further than we ever thought possible, should our final days just be free of pain, or do we actually have a right to pleasure? It's a fascinating proposal, right? One that truly challenges the very foundation of bioethics. Thank you so much for joining me on this explainer today, and hey, keep questioning the world around you.